Hi, this is Mrs. Lewicki, and this is the fourth and final voiceover PowerPoint for respiratory content for NP4. We're going to talk about respiratory failure, and respiratory failure is described as either hypoxemic or hypercapnic. Failure results when gas exchange is inadequate. So your PaO2 is less than 60 with oxygen at 60%. Now, remember that you or I don't require oxygen. So anybody who requires oxygen is compromised. So if somebody is requiring 60% of oxygen or higher and still has a PaO2 of less than 60, that's pretty severe. Additionally, in addition, it can be hypercapnic, where they have a PaO2 of greater than 48 with a pH of 7.35. Causes of hypoxemic, sorry, causes of hypoxemic respiratory failure include ARDS, pneumonia, toxic inhalation, pulmonary embolism, and cardiac disorders. And causes of hypercapnic respiratory failure include COPD, cystic fibrosis, changes in your central nervous system, or chest wall problems, and neuromuscular disease. Remember, the function of the respiratory system is gas exchange. So oxygen in, CO2 out. Failure results when we're unable to do that process. It's not a disease, but a condition that occurs as a result of one or more diseases of the lung or other body systems. So other clinical manifestations, clinical manifestations include rapid shallow breathing that progresses to slow respiratory rate, tachycardia, and activity intolerance. And they're going to show the signs of air hunger. Diagnostics, chest x-ray, ABG, CBC, EKG, VQ scan, CT scan, and pulmonary artery catheter. Patient will likely be intubated and ventilated and then placed on medications. Some of the medications that we'll use will depend on what the cause of respiratory failure is. So if we're trying to decrease the pulmonary congestion, they may be placed on diuretics. Remember, diuretics help to eliminate some of the excess fluid. They may be placed on morphine, and sometimes that's to help relax them, and it can reduce their respiratory rate, but it also helps to reduce the preload. So how much volume is going into the ventricles. Nitroglycerin for the same reason. Nitroglycerin vasodilates, so it helps to relieve some of that pulmonary congestion. For their airway, they may be placed on bronchodilators, and those help relieve bronchospasms. And corticosteroids help to reduce airway inflammation. They may be on medications for agitation and anxiety, such as Ativan, Versed, Diprivan. There's another one, Precedex. I can't remember what the generic name is for that. And we'll talk about those in just a minute. And they may be on antibiotics to treat infections. If somebody's in respiratory failure, my goal is to adequately ventilate them. They need to be ventilated properly in order for gas exchange to occur. So they may not require any help as far as sedation or analgesia occur. Yeah, as far as analgesia or sedation. But they may require a low level of sedation in order to properly ventilate them. And basically, we progressively add medications in order to properly ventilate them. So we would start with an Ativan and a morphine, and then we might go to instead a propofol or a Precedex, and if necessary, we might even get to a paralytic, and if we, which is a neuromuscular blockade agent. If we go with a neuromuscular blockade agent, remember there's no pain manage, no analgesia effect, and no anesthetic effect. So the patient would also need to be on morphine, pain management and sedation. Um, uh, Acute respiratory distress syndrome, or ARDS, is a type of respiratory failure. It was first defined in 1967. They called it pump lung because of being on the bypass surgery, traumatic wet lung, shock lung. And what it is, it's a sudden and progressive form of acute respiratory failure. The capillary membranes become damaged and more permeable, and so the alveoli will fill with fluid. The surfactant is inactivated. They get congestive atelectasis, alveolar debris, and membrane formation. And because of that, how it's a whiteout on the x-ray, but sometimes they describe it as it looks like ground glass in the x-ray. There's direct and indirect causes. Direct lung injury, common causes include aspiration of noxious substances and viral and bacterial pneumonia. Less common causes are chest trauma, embolism, inhalation of toxic substances, um, near drowning, O2 toxicity, and radiation pneumonia. Indirect lung injury, common causes include sepsis and massive trauma, and other causes are pulmonary embolism, shock, acute pancreatitis, anaphylaxis, cardiopulmonary bypass, DIC, multiple blood transfusion, drug overdose, near drowning are other causes. It is a very high mortality rate if somebody gets diagnosed with ARDS. It's a disease that progresses through several stages. Stage 1, they have dyspnea, especially on exertion, and they have decreased breath sounds. Stage 2, you see more signs of respiratory distress. They develop tachycardia, restless, agitated, and they have crackles. In stage 3, they're in obvious respiratory distress, increasing tachycardia, labile blood pressure, they become cyanotic, and at this point, if it hasn't been done already, they require intubation and ventilation at this point. Stage 4, they have a decreased respiratory rate and heart rate. They have a decreased level of consciousness to unconsciousness. Their skin is cool and cyanotic, and they have severely diminished breath sounds. Treatment is they need to be in the intensive care unit. They need to be intubated and ventilated. They will need to be on PEEP, and we'll talk about the vent settings in just a few minutes. But PEEP is positive end expiratory pressure. And what that does is it keeps the alveoli from completely collapsing on exhalation. If you think about blowing up a balloon and then letting the air out and you leave a little bit of air in there, how much easier it is for that balloon to blow up. That's what PEEP is that little bit of air. With you or I sitting here with no ET tube, endotracheal tube, we have PEEP. It's anatomical PEEP because our breath exhales through our vocal cords, through our glottis, and through bone structure. And so we have that ability. With somebody with ARDS, the purpose of PEEP, is that it keeps the alveoli from completely collapsing, and the alveoli can stay in contact with the capillary bed, which is where the gas exchange occurs. And so if somebody has ARDS, we know that they need a little bit more PEEP. I'm not going to give you numbers, but the normal, everybody on a ventilator gets +5. So somebody with ARDS might get plus 7.5 or +10. And that's to keep that a little bit more of that alveoli in contact with the capillary bed to help improve gas exchange. They may be on an inverse ratio ventilation, which normal inhalation or normal inhalation to exhalation is 3 times longer than inspiration. And so what they will do is inverse that ratio, making a longer inspiratory period and a shorter expiratory period. They may also do high frequency ventilation, which if you did any time in neonatal, you might have seen that. They call that the oscillator. And basically it's like giving breaths like this, super fast, like 300 megahertz a minute. So they give a lot of breaths for that. And the other thing that we might do is prone position them. And by putting them on their stomach, it helps to expand that lung area by opening it up, similar to how an orthopnic position would work. The thing about prone positioning is that it is a labor intensive as far as getting them into that position, but also there's not necessarily improved outcomes with it. So there's no data to support that. We do see a temporary rise in the in their PaO2 though when we do that. We did talk about all of these medications already, and I just did want to add that they may, with ARDS, because they become hypotensive, they may need to have medications to counteract the low blood pressure. This is a patient in the prone position. You see, I don't know if you can see that, but they put the ECG leads on the back. Trying to get a good color marker here. So they put the ECG on the back. They're intubated, ventilated. There's IV pumps. That's a tube feeding pump. So there's all kinds of stuff going on. But we want to maintain the airway. So if we're going to prone the patient, we have to make sure that respiratory therapy is there to make sure that they're managing that airway, and that's their job there. Reposition them frequently, manage the blood pressure, and manage IV fluids. And they do know that if we reposition the patient frequently, as in every 20 minutes, that we can improve their outcomes. However, that's not always possible. And even with the beds that will rotate them, we set them on a time interval to rotate them. Sometimes their blood pressure doesn't tolerate that repositioning. So sometimes it's just a very gentle 5-degree or 10-degree turn, depending on how stable the patient is. SARS, or severe acute respiratory syndrome, there's not much in your book about this, but it's a coronavirus. It's spread by close contact with people, most likely droplet spray. They present with flu-like symptoms, maybe direct contact, and 80 to 90% start to recover by about day 6. 10 to 20% develop severe respiratory problems. And if that happens, their risk of death is greater. That group often has comorbidities. Cause is hypoxemic, flu-like symptoms, cough, fever, headache, sore throat, low white blood cell count, dyspnea, joint pain, and malaise. Clinical, so that was clinical manifestations too. Other manifestations: rapid shallow breathing, progressive to slow respiratory rate, tachycardia, activity intolerance. The diagnostics are the same. Treatments start before confirmed isolation. They may be on start before it's confirmed SARS. And you may or may not remember, it was about 10 or 12 years ago, maybe 15 years ago, that there was a big outbreak. And the people who got the sickest were healthcare workers, because we didn't properly isolate the patients. And so the hospitals do surveillance, and you should be aware that that's happening. And so you want to properly isolate, make sure they start on antiviral medications such as ribavirin. Antibiotics will treat or prevent secondary bacterial infections, and corticosteroids. Mechanical ventilation, we look at a few things. Who needs to be ventilated? And we look at different things. There's ventilation, and there's respirations. And so ventilations is the act of breathing in and out, and respiration is the gas exchange that's occurring. So people who need ventilators are people who are apneic or impending inability to breathe, acute respiratory failure, severe hypoxia, or respiratory muscle fatigue. There's a couple of types. There's negative pressure, which is not non-invasive. It includes things like the iron lung. It's similar to normal ventilation, decreased intrathoracic pressure on inspiration, and expiration is passive. And then there's positive pressure ventilations. Ventilator pushes the air into the lungs under positive pressure, and expiration is passive. This type requires an ET tube or tracheostomy. When we're looking at modes of ventilation, we also have two different types. We have volume ventilation and pressure ventilation. And volume ventilation, they do a predetermined tidal volume, and the ventilator is going to deliver that tidal volume. It's based on ideal body weight. We used to do a lot higher total tidal volume, but with so many cases of ARDS developing, they now do a much lower tidal volume. And it requires pressure to deliver the tidal volume, and it's going to push that in. One of the biggest modes we see is assist control. Pressure ventilation is a predetermined peak inspiratory pressure because we know that what we do, while we can do it and do it well, it's not always the best for the patient. And we found that by pushing it too much volume, it can destroy alveoli. And so because of that, they developed a pressure ventilation. And what they do is they'll deliver the tidal volume until it reaches a certain inspiratory pressure, and they won't push back past that. And those types are called pressure control ventilation or pressure control inverse ratio. Most of the time we do a marriage of both. And so it would be a VC plus, so it'll be volume control plus pressure. And there's different names, and the names, believe it or not, are proprietary for the ventilator. So just have an understanding of how that works. Um, I'm not going to get into the pressure control inverse ratio. You can read that. We talked briefly already about high frequency ventilation. We talked about PEEP. And if you only understand one thing of everything I'm talking about, understand that one. There's also continuous positive airway pressure. And that's usually some inspiratory support because when they're intubated, it's like breathing through a straw. So it gives a little support on inspiration. And then bi-level or BiPAP. So CPAP, they can be ventilated, or you've heard of sleep apnea and people being on CPAP at home. So they could have a mask for that. BiPAP it's non-invasive, so they're not intubated, and the patient gets inspiratory and expiratory support for their breathing. What's the nurse's job with a ventilator? We're going to show you in class how to assist with intubation, and we'll, if we can, look at a ventilator. But we're responsible for alarms because there's one respiratory therapist for every 20 patients and one nurse for every 2 or 3. So we have to look at the alarms. There's high pressure alarms and low pressure alarms, and those are the main ones you have to worry about. All of these other alarms, the apnea alarm, the ventilator is set to even if the apnea alarm is going off, that it's set to give the patient about 4 or 6 breaths per minute. So you want respiratory therapy for those. But let's think about what causes high pressure. High pressure alarms are things like the patient's biting on the ET tube, or it's kinked, or there's some kind of mucus in there. So my job with that is to suction the patient, to maybe medicate them if they're biting the tube. Talk to respiratory about putting in a bite block. Things like that for high pressure alarms. Low pressure alarms is that ventilator is trying to give the breaths and it's going nowhere. It's not meeting any pressure. It's just going out into the air. That means either the ventilator became disconnected or the patient pulled out their ET tube or things like that. And so what's my job with that? What do you do if the patient pulls out their ET tube? Well, depends on how much oxygen they were on, how much support they needed. You're going to call for help, but if they were on a lot of support and pulled out their ET tube, they need to get intubated again right away. So you might need to call a code. But if they were getting ready to be extubated anyway, you might want to just get the ambu bag, the bag valve mask, and start giving them breaths. If somebody's on a ventilator at your bedside, should always be the oral airways. We talked about that in the first PowerPoint. You need to make sure you have a bag valve mask, and it needs to be hooked up to oxygen, suction, and a syringe. And the syringe is because, remember back on the first PowerPoint, the ET tube has a cuff, and that's inflated with air. And that's respiratory's responsibility, but we always keep that at the bedside. It's our job to do respiratory assessment. We do monitor the ventilator settings and where the ET tube is, um, because we're the eyes and ears. And so I want to know if they increase my oxygen or my PEEP, or if they're starting to wean the patient. And while communication between respiratory and nursing is generally very good, it's still important, sometimes you're at lunch or with your other patient and they need to make changes. And so that's why it's important for me to look at those settings. I want to maintain appropriate cuff pressure. Now, with BAP prevention, that's now the responsibility of the RT, and they go around and check using a sphygmomanometer. They go around and check the pressure and make sure that's adequate. Develop a plan for communication, and on our Canvas page, there's a document on how to communicate with a patient with an ET tube. My job is to administer medications, I help with suctioning, and I assist with weaning, and I monitor the patient when they're being weaned. I also look at sedation vacations. I'm the one that turns um, the sedation off and monitors the patient to see if we need to resume that. And that concludes the PowerPoints.